Welcome to AETCM, the Emergency Medicine channel. Today we'll be discussing about a 48-year-old male who was brought to here with complaints of alleged history of road traffic accident. So a 48-year-old male was brought to here with alleged history of a road traffic accident. Basically, he was a single two-wheeler rider, helmeted, and he was hit by a car from behind. And he fell on his left side, and after that, he was complaining of some left lower limb pain. But the bystanders took him to a local hospital. At that time, he was a bit confused. But in the nearby hospital, they did some primary care only and then shifted the patient to our hospital for further management.
What is the reason for confusion after head trauma?
The most common would be something called concussion. Because sudden shaking of brain can actually make the patient confused for a few hours. Countercoup injury and all that. So it can either be a contusion or maybe like a sudden shaking movement. So the primary symptoms will be patient will be repeatedly saying the same thing again and over again. Okay. It's mostly commonly sign of concussion.
What else?
Then maybe the patient, if a diabetic or something, we have to think about hypoglycemia or something. Okay. We have then
inebriated state, alcohol intoxication.
Okay. And again any diffuse axonal injury. Then seizure.
Axonal injury takes time. Seizure. Post-head injury, seizures can present with altered behavior after some time. Okay.
So this patient had some altered behavior.
Concussion is the most common thing what we see.
So this patient mainly had mild confusion, but otherwise he was obeying commands and all that. And he complained mainly of left lower leg pain. So after giving primary care, he was shifted to another hospital for further management. So patient was received in a trolley to our hospital and he was shifted to our ER bed. So while receiving, we shifted him in a spine board, and just receiving on the bed, we just looked for the log rod. There was no spinal tenderness as such, but he was a bit confused, but there was no obvious injuries or any deformity or tenderness noted. So we received a patient in our ER bed and continued our primary assessment. So initial tendency assessment, the patient was conscious and he was obeying commands intermittently, but sometimes he was a bit confused. So we went to the primary survey. Airway, there was no signs of any airway obstruction. There was no stridor, there was no pooling of secretions, there was no gurgling. But C-spine we immediately secured with this Philadelphia collar. So airway was maintainable and patent, and C-spine was secured. We went to the breathing part. He had a respiratory rate of 22 per minute, and respiratory was 98% in room air. He had symmetrical and adequate chest excursions. Chest on auscultation was clear with bilateral equal air entry. Circulatory part, he had a BP of 130/70 and also a heart rate of 94 per minute. At this point, actually, we noted he had only one 20-gauge cannula from Musculoskeletal Hospital, so we secured two large bore 18-gauge cannulas on both upper limbs. There was no obvious injuries on the upper limb, so we secured on each limb 18-gauge cannula.
Why 18-gauge cannula?
It's preferable to get at least two good large bore cannulas in case we want to rush fluids or something, because as the gauge goes down, it will be difficult to resuscitate the patient in an aggressive fashion. Suppose we need one. Okay. And also we had to ideally get at least two cannulas, because if one can suddenly blocked or something, we have one more to go for. So we circulatory part, we took got two large bore cannulas, and disability part, again he had a GCs of E4, V4 and M6. Only the V was affected. Okay. And pupils are equally reactive, two of them bilaterally reactive. And because of his altered sensorium, we checked the GRBS. It was 121 milligram per deciliter. His pain score was not able to be we were not able to assess because of his confusion, but he appeared to be in pain because of his grimacing and movements and all that. So we gave him paracetamol. 1 gram IV was given, and then we continued our survey. The exposure part, he was actually having normal temperature was normal. Peripheral pulses were equally palpable on all four limbs, and there were no any obvious bleeding spots or any major open wounds noted. We also quickly exposed and covered each and every area to look for any obvious injuries or deformities, but none was noted except for the left lower limb. There was some contusion and some deformity in the left lower limb, but otherwise he was maintaining. And we took some primary adjuncts. In that we took a VBG, which was easily accessible in our department. It worked with the normal limits. There was no acid-base arrangement, and HP in our we get HP in our VBG. It was about 14.1, and lactate was also normal. And we also took an USG fast, which was easily accessible in the hospital. So USG was not showing any free collection, and also extended fast. There was no signs of any pneumothorax or pleural effusion.
Pneumothorax, what finding you got?
We can get absolute lung sliding sign. So suppose we are suspecting pneumothorax, we can have an accessible USG machine. We can check both lung fields from second intercostal space up to the axilla. Each rib space we have to check for lung sliding. Suppose we are like if the suspected
Staining
area
will be absent.
will be absent. We will be able to see like silver glistening lines moving, which can indicate the movement of pleura and the lungs.
What is barcode sign?
Suppose we are suspecting like a absent lung slide, we can put it on an M mode, and there actually we can see either a seashore or a barcode sign. Seashore is normal. Suppose the differentiation is completely gone, we get a barcode sign, which is indicating more of a pneumothorax. So this patient doesn't have any of this.
What is blue protocol?
Blue protocol is a bedside lung ultrasound that we do, sir. That is to check for, basically it is bedside lung ultrasound done in emergency. That's the full form of blue protocol, wherein there are denoted as A, B, C.
Yes.
So there is a certain and with A dash and B dash, that dash is common. So then it's done bedside in two places we check. One is in the posterior most part, that is the posterior axillary line to the lowest part is called as the pleural point, wherein we'll hold in to check. That's the most sensitive area for any effusion, to look for any effusion. The other area is A, that is in the anterior axillary to the mid-clavicular area. So there, if at all there is any pleural effusion, not pleural effusion, pneumothorax, then you will have it as an A dash. Otherwise, it is a normal finding.
So basically, anterior and posterior to the axillary lines, we check for any obvious lung issues in emergency. So either you can denote pneumothorax or even effusion.
Consolidation.
Like here, hemothorax also picked up.
So this was our primary adjuncts. We went to secondary survey. So he was a 48-year-old male. So he was riding a two-wheeler.
What are things you can pick up by ultrasound?
Chest.
Other than pneumothorax and pleural effusion.
So consolidation can be seen. It can be seen as a tissue-like sign of the starry skin appearance. Pleural effusion will see a fishtail appearance, wherein we'll see the collapsed part of the lung floating in the fluid, pleural fluid.
Then we can assess the A line, B line, and all that. A lines are normal. Pulmonary edema.
Pneumothorax, pulmonary edema.
Then also we can go for echo to rule out the.
Echo is a different.
In lung. So secondary survey, we took a detailed history with from the bystanders. So he was a 48-year-old man. He was traveling alone, helmeted, and he was hit by a car as per given the history given by the people who saw the incident. He fell on his left side, and immediately he had a transient LOC for some time, and followed by multiple episodes of vomiting. About 4 or 5 episodes of vomiting was there, but after that he was completely conscious. There was no seizure episode, and obviously.
What are the signs of raised ICP?
One thing will be altered sensory.
So these are the things we are going to document in any patient who is admitted in emergency room.
So following a head injury, the patient is having some loss of consciousness.
That is not the sign of...
not sign.
It's not the sign. Can be the...
Projectile vomiting.
Then anisocoria, and if we have the facility for a bedside... no, what's that? Ophthalmoscope, we can see for papilledema. Fundoscopy, you can see for papilledema.
One more sign.
Seizure.
Bradycardia.
Cushing's reflex.
Bradycardia, anisocoria, projectile vomiting. These things we have to monitor every half an hour in a patient who is admitted with head injury. Okay.
So this patient had a transient LOC.
Before, when there was no CT scan, or if you are working in a facility where CT scan is not available, every half an hour you have to monitor for next 24 hours. Then you can discharge the patient. So in a hospital like this, we have CT scan, we can immediately roll out. But if you are working in a place where there is emergency CT is not available, you have to monitor this patient for 24 hours. Okay.
So this patient had a history of head injury with some transient LOC and multiple episodes of vomiting. There was no history of any seizure or any ENT bleed noted. And after the incident, he was not able to...
So memory loss also, you have to see whether it's a transient memory loss, whether he remember previous things, amnesia. All these things should be documented properly.
So after the incident, he was not able to bear his own weight, and he was complaining of left lower leg pain. So he was taken to a nearby hospital, and their primary care was given. They give some medication, and also they put a long splint on the left leg because he was complaining of pain. Then shifted to our hospital.
Why we are putting a splint in patient who is having fracture?
To stop mobilizing.
One is to remove the pain. So if it is moving, then it can produce pain. Other things?
To stop the... during the fracture, there is increased chance for bleeding. Bleeding points can occur.
What is that? Bleeding is one part.
So one is basically because of the fracture, mobility of the fractured fragments can increase the pressure. It can lead to compartment syndrome.
Okay, repeated injury can produce repeated wounds and
Movements.
compartment
Then,
syndrome.
for as a sign of hemostasis, also we can do it.
Other things, it can injure the arteries, veins, and nerves. So that is
Basically,
also very important.
fracture fragments can actually, on mobility again, can injure the nearby vascular structures.
So that is very important. So even if we cannot fix the problem, we just stabilize the leg. That is more than enough. Okay.
So our priority in case of suspected fracture will be to mobilize the joint above and below, including that affected area. So one thing is you can reduce the pain by reducing the movement. Then actually by properly stretching the wound, it can actually avoid further collection of blood. And also
That's why previously they used to put traction and fix the area. Then the orthopedician can come and
initially they used to put skin traction and then fix the area, or like manual traction. But then third will be like to prevent further damage to the vascular structure.
So if you are transporting a patient, you give a small traction and put a splint and transport. Here we have orthopedicians, so they'll take over immediately.
So this patient actually they had a splint in the hospital available, so they put him on that and shifted the patient to the hospital. So otherwise history, he doesn't have any non-comorbidities, he's not on any medication and doesn't have any non-drug allergies. His last meal was about 8 hours before coming to the hospital. Before the incident, about
Why you are taking a joint above, joint below the fracture?
thing is for mobilization mainly.
Articulation, any intra-articular
Because
fractures or
dislocation can occur there. We don't know. His main pain is the fracture area. Here also dislocation can occur. So that we will not be noticing. So we have to rule out that also.
Because when an impact occurs, the impact can transfer along to the nearby joints also. But because of distracting pain, he will be focusing only on that area.
Yes.
So we have to rule out other areas also. So this patient doesn't have any significant medical or surgical history in the past, and last meal was about 8 hours back. The only event was
So how many X-rays you will take in this patient? Minimum.
3.
minimum
One
actually.
is 3 and cervical spine is always anybody chest X-ray like that patient is having pain there. So minimum that joint 3 and one cervical spine is always has to be there. Then wherever he is having pain, that also can be taken.
So this patient, especially when the injuries on the lower leg, we have to think about the injuries affecting the lower leg, knee, and also even in the hip also. So we can go for a hip, knee, and lower limb, and also if ankle if required.
Okay.
And so that was our plan in the ortho side. So far no medical reason, no drug allergies or no medications he's taking, no significant medical or past surgical history, and last meal was about 8 hours back. This was the basic history. I went to the clinical examination. So we have both general and head-to-toe examination. Generally, actually, he was somewhat conscious but still confused. So we went ahead with the, but so far his C-spine is stabilized, he otherwise maintaining. So we went to the head-to-toe examination. In the head part, he had some minor abrasions on the left side of forehead and over the nose, but there was no deep lacerations or any injuries noted. Otherwise, than the small abrasions.
Oral cavity you want to examine?
There was no signs of ENT bleed. There was no nose, ear, or oral cavity bleed.
Okay.
And teeth, there were no mobile teeth or anything noted.
Artificial teeth is not.
And also they went to the C-spine. C-spine is already stabilized, so we couldn't assess that. But then clavicle wise, there was no exchanges over the clavicle or deformity.
You want to remove the collar now?
No, considering his sensorium, there is no point in removing or assessing the collar, and also we have to anyway go for imaging in this patient.
Only after imaging, if it is ruled out,
Then we can remove.
No larynx area.
There was no like tracheal shift or any laryngeal abnormality noted.
that is for what?
Trachea was central.
Tracheal lacerations, surgical, subcutaneous emphysema.
But you are not seeing anything here. Why you want to see the trachea?
One thing is we can rule out suspect pneumothorax if there is
Pneumothorax,
tracheal deviation.
both can be ruled out. Possibly ruled out, not completely. Can be.
So distended neck veins, tracheal deviation can all give a suspicion of pneumothorax or even pericardial effusion. So this we can look for the
pericardial effusion, trachea.
distended neck veins.
Okay.
Again, we give a clue. And so there
What are
also
the signs of tension pneumothorax and massive pericardial effusion?
tension pneumothorax actually most significant will be like inadequate chest excursion or asymmetrical chest excursion. One side will be moving, one
Flail
side
chest.
then flail chest can be there, and also then any obvious injuries over the chest which we can see. Then there will be tracheal deviation may be there,
Okay.
and also there will be distended neck.
Tension pneumothorax.
Tension
We are
pneumothorax.
telling about the signs of pneumothorax.
Instability,
Instability.
hypotension, absent breath sounds, severe respiratory distress with distended neck
Bradycardia,
Hypoxia.
hypotension, and
absent breath
reduced
sounds.
breath sound. This is a sign of. These are three important signs of tension
Tension
pneumothorax.
pneumothorax.
Whereas cardiac tamponade.
It will be Beck's triad, hypotension, muffled heart sounds, and distended JVP.
Okay. So if there is pneumothorax on the left side, you get all these things. Muffled heart sounds are there. Then hypotension is there.
Distended
Bradycardia is there. Distended neck veins are there. So all are there even in pneumothorax. So Beck's triad is also described in tension pneumothorax, especially on the left side. Okay.
So this patient doesn't have any those kind of features, and in the C-spine part, we also simply palpated the neck for any subcutaneous emphysema, which was not there. Then clavicle, there was no external injuries or deformity noted. Chest compression was negative, and also there was no external injuries noted, and there was no signs of any subcutaneous emphysema or anything, and also adequate chest excursions were there. Auscultation, again, he had bilateral equal air entry. Abdomen was soft and non-tender. There was no external bruise or contusion noted, and there was no fullness or any obvious collection noted in the abdomen. Then pelvis compression was intact. There was no giving away feeling or in the pelvis. Log roll we already did. There was no obvious spinal tenderness or deformity noted, which we did while we were receiving the patient. Then we went to the musculoskeletal examination. So
ideally, you have to see the external meatus, whether any bleeding is there, and you have to see the anal reflex. Why anal reflex?
Which can actually in some case
spinal injury, spinal trauma, which produces
this thing,
complete like lower limb weakness with the flaccidity can be the spine. Anal reflex can be flaccid. Okay.
So after that,
after having the CT scan and all, the need of all these things are come down. Spinal shock. But if you are examining the patient like systematically, all these things should be done.
So after this, we went to the musculoskeletal examination. We went with each upper and lower limb. So right upper limb was not showing any external injuries and which had full range of motion. Left side there was a small condition of the left shoulder, but he was able to we were able to move full range of motion. Right lower limb was also appears to be normal. On the left side there were small contusions and multiple abrasions all over the limb, mainly noted about 15 centimeters above the left angle. There was a contusion with some deformity and tenderness. There was no signs of any open wound or any active bleeding spots present. So this was already in the immobilized limb. So our plan was to go ahead with an X-ray to rule out any obvious fracture. But we went checked the distal pulses and the saturation in both lower limb. Both were equal. 98% was there, and distal pulses were confirmed by handheld Doppler. It was also present in both lower limb equally. So after that, so our impression was most probably
handheld Doppler only produces sound. No?
So we can only appreciate
sound. Only appreciate sound. So but if you have a ultrasound machine with Doppler, you can even see the vascularity also.
This was quickly accessible, so we just checked for this one. So our impression was basically most probably a traumatic brain injury because of his confusion and all that which we had to roll out, and also most probably some injury over the left lower limb. So after stabilization, after all this assessment, he was still maintaining our basic primary survey, airway, breathing, circulation is maintaining. So we went ahead with our investigations. We went for a CT brain with a CT C-spine. C-spine was normal, but brain was showing a mild, thin rim of extra-axial hyperdensity involving the bilateral frontal regions with a maximum thickness of 3.7 mm in the right frontal region, so history of a bifrontal SDH. But there was no signs of any midline shift or significant deviation noted. So it was more like a thin SDH on bifrontal areas. The next ray taken was showing a
acute frontal lobe lesion. What all clinical findings can be there? If it is affecting the brain, what all clinical findings can be there? Frontal area, bifrontal.
Behavior problem will be the
main thing is behavior problem, urinary incontinence and lower limb weakness, bilateral lower limb weakness. Speech is normally not involved. Speech is normally not involved, but altered behavior that he may not irritability and that social inhibition will be lost, and bilateral lower limb weakness can be there. Bladder can be What bladder involvement can be there?
Incontinence, that you have a maturation center is there in the front.
social inhibition will be
is
gone.
absent. Maturation center is not in the frontal lobe. That only controls the social inhibition. Okay. They'll pass urine without
any prompt. So that was in the CT part, and X-ray was taken. We were showing a fracture of both shaft of tibia and fibula on the left lower limb.
Any nasal bone fracture?
No.
Nothing else.
No. There was no sinus fracture, nasal bone fracture, or any calvaryal fractures not. Also, there was no signs of any extra-axial bleed also. Only one thin bilateral STH was noted. And there was also not much significant cerebral edema or midline shift noted. There was also no signs of any pneumocephalus. So this was in the CT, and X-ray was showing a bilateral shaft of both tibia and fibula fracture on the left lower limb with no continuity to the membrane or anything. So it was like a closed fracture, both bone fracture of left tibia. So it was our patient mainly with a traumatic brain injury with a GCS of around 14 with a bilateral lower limb edema, bilateral lower limb fracture. So he was admitted for further evaluation. So considering his injuries, we gave both neurosurgical and orthopedic team get involved in the management. From a neurosurgery side, actually, considering his symptoms,
from an ER side, it is mainly pain management and monitoring the patient's GCS and other raised ICP features.
So pain, actually, this patient, actually we can pay pains. We usually go for pain score in ER. We can give the patient a subjective pain score, asking him to give me a rating from 0 to 10, and considering his rating, we give pain score analgesia according to the WHO pain ladder scale. Like mild pain, we start with analgesic like paracetamol, and medium we go like a low grade opioids and a combination of paracetamol, and high grade we go for a high grade and this thing analgesic like fentanyl. But this patient, we are not able to assess the actual pain score. In such cases, we can also go for other scales like visual analog scale or even facial grimacing scale. So suppose the patient is showing so much of grimacing, we can assume it like a significant pain and we can give painkillers. So it is actually highly important to reduce pain in case of suspected head injury, because when pain can increase the ICP. So this patient, after giving paracetamol, he was comparatively calm, so we didn't offer any more painkillers. And so also if you're giving tramadol or anything, it can even precipitate seizures. So we want not to avoid that, we stopped with paracetamol. So this patient was in ER. The main thing was pain management, and also we continuously monitored the patient for any worsening of his GCS. And also in case of trauma patients, we usually monitor the motor component, because actually sometimes the patient may have some initial confusion on arrival, but the motor component, even a single point worsening indicates an acute worsening of the sensorium. So this patient was maintaining that, and so he was admitted and for further evaluation observation. So the main plan was under neurosurgery side for conservative management, that is observation of monitoring of GCS and other conservative managements. And then once the patient improves on his further CT, repeat CTs, then they were planning for surgery. So from the management part, there are multiple things we have to think about managing a brain injury patient. So there are different goals which we try to maintain to bring the body's homeostasis. So the patient is having a head injury, our priority will be to maintain the body to as close to a homeostatic situation as possible. So starting with oxygenation, we have to maintain at least 90% above SpO2, and also BP should be maintained with a map of at least above 80 millimeters of mercury. So the idea behind this is basically the patient having some sort of raised ICP, which can have the cerebral perfusion pressure compromised. So the formula is CPP is equal to MAP minus ICP. That is, cerebral perfusion pressure is a difference between mean arterial pressure and ICP. So anytime the ICP is increasing, it can compromise the cerebral perfusion pressure. So this patient, we try to if the patient is having a high BP, we try not to reduce it and maintain it at that point, which is more of a physiological response to maintaining the cerebral perfusion pressure.
But if the BP increases high, without any intracerebral pressure, what it tells you?
Basically, we have
one of the common problem in post-trauma, post-surgery case, high BP. If you go to surgical ICUs, you can see many patients will have very high BP. Why it is like that?
One is because of pain.
It is mainly because of pain. Pain and anxiety. Pain is the most important part of condition which can increase the BP, especially post-trauma, post-surgery. So in that condition, what you do?
One thing is like
Anxiolytics.
So pain management is main thing, not controlling the BP. Controlling the BP sometimes it will adversely affects the patient. So here pain management is most important than controlling the BP. BP will get controlled once you control the pain.
these patients actually we can go for intermittent boluses of painkillers, or even we can go continuous slow small infusions we can maintain to control the pain.
We don't want like this patient to continuously go for sedation. Okay, that is also wrong. Because he is having an head injury. You want to monitor this patient. If you are
Giving
working in a
sedatives.
busy emergency room, please completely sedate the patient. We will not be knowing what is happening to the patient. Okay.
So intermittent painkillers as required we can give. So then BP management, then hypoxia we have to prevent with MAP at least above 80 mm if it's an isolated head injury. Then actually the PaCO2 value we have to maintain between 35 to 45.
Okay.
Previously we used to hyperventilate the patient suspecting head injury, but the current guidelines says it's only as a temporary measure. Suppose we
It's only a very transient effect. What will happen to the cerebral blood vessels if there is hypocarbia?
Basically, hypocarbia can cause cerebral vasoconstriction.
Yes.
So it can again help in controlling this thing.
It's
Further
only a transient effect. And sometimes it can worsen the patient also.
So it is not usually indicated, but in case of a transient this thing,
If you are taking for the surgery, if you want to get some time, you can
just
try
before
all
shifting for surgery and all, we can try for a hyperventilation of the patient.
Okay.
The temperature also we have to maintain normal tension. It shouldn't go hypothermia or hypothermia.
Okay.
And also this thing, the pH of the patient should be maintained between 7.35 to 7.45. So any other metabolic issues he is having along with this condition, we have to tackle and maintain the pH between that normal range.
What are the common conditions which can alter the pH after
Suppose
trauma?
one thing is this thing, significant loss of blood or anything like tissue hypoxia, lactic acidosis.
One is lactic acidosis. Second common cause is
Vomiting
decay.
Decay.
That produces alkalosis. Decay. If you see trauma cases, many patients who are diabetic, they go to decay after a trauma. Okay, so we should be very careful. So lactic acidosis is a common thing because of trauma. In diabetic patient, they if you don't treat properly, they develop decay in first day or second day itself. Okay.
So that's the next goal. We should maintain the blood sugar between 100 to 180 millimeters milligram per deciliter. So or 80 to 180 milligram per deciliter.
Okay.
So a normal glucose range, then normal pH range, and next we have to maintain an upper limit of physiological sodium. Like 134, 144, at least around 145 we have to maintain.
Except sodium, all should be in the physiological
range.
Sodium has to be slightly higher than the
Even up to
upper limit
150.
of the
We can even push up to 150. We can.
What is the action of sodium in brain?
Ideally, actually,
If you increase the sodium, what happens?
Anti-edema, it causes shrinkage of this.
Okay, it draws blood from the cell, so the cell edema can come down.
So it's used as an anti-edema measure. So ideally, in case of an acute event, we usually go for mannitol, but as a prolonged continuous medication, we go for 3% saline, or hypertonic saline. And also suppose the patient on arrival is having low hemoglobin, which also we have to correct to maintain at least 8 gram per deciliter we have to maintain.
Okay.
So suppose these are the initial managements which are goals we go direct towards a head injury patient. So even in a year we can start this management.
Head and elevation?
A head and elevation should be there. At least 30 degree we have to maintain.
So from here we have to follow these basic steps. Okay.
So as much as possible, we try to maintain the patient to a normalized this thing as possible. Like provide adequate oxygenation, adequate blood pressure, adequate temperature, then maintaining proper nutrition, like maintaining normal glucose level, normal physiological pH, and also, if required, antidote measures like 3% saline.
Okay.
So this was our basic management, and again pain management. And so this patient got admitted for evaluation and observation. The initial 2 days he was actually having some sensorium deficit was there, but it improved over time. And the repeat CT was showing actually an improvement of the bleed. It was almost resolving. And by about fourth day he was taken up for surgery. Nailing was done for both the shaft, and after that post-op phase there was uneventful. He was recovering properly, and now he is in the post-op part.
Can you give DVT prophylaxis?
And this patient, the thing is, initially because of head injury, we are not supposed to give because it can worsen the bleed. So once it's showing resolution of the bleed, we can go for DVT prophylaxis. Heparinoclexane can be used. So this patient
Normally DVT prophylaxis will not increase the bleed. Normally. if the patient does not have liver disease or anything else. Okay. Normally, it will not alter the bleeding parameter. It is
DVT
only.
prophylaxis can be given, not just pharmacological. Otherwise, the
It is
this
ideally
bleed.
it can be given. Okay.
Okay.
You don't need to worry about the bleed because it will not produce clinical bleeding.
Okay.
Okay. Because if the dose is not
That
to produce bleed, it's a very mild dose. Okay.
So our patient mainly was taken up for surgery on the fourth day of following this admission, and after that now he's undergoing his post-op uneventful. So that was that. So suppose a patient is coming to ED with suspicion of head injury. Two things is actually along with head we have to stabilize the C-spine also.
Okay.
And in this actually we can use two criteria either to roll out or to take which indicate a CT C-spine or CT or like X-ray imaging of C-spine. So the most commonly used nexus criteria. You can easily remember the abbreviation NSAID. Basically, there is any neurological deficit or any spinal tenderness noted, any altered sensorium or any intoxication like alcohol, and also any the distracting injury. So this patient had two. Basically, he was in altered sensorium and also had a distracting injury. So there was a definite indication for nexus criteria to go for an imaging, but it was mainly indicated for like X-ray. But thing is, the current guidelines are more in favor of going directly for a CT C-spine, especially if you're going for a head imaging. So this patient we opted for CT C-spine. And again, this patient, suppose that we are having like a high velocity injury or like a patient who is having age above 65 or maybe like a fall from at least more than 6 feet height or something, he definitely have to go for an imaging without any second choice. So
In bike accident, how do you get high velocity injury?
bike accident actually
This is not a high velocity
no.
injury. This is hitting from back.
bike accident depending on the like the speed we can
High speed, they go and hit against another object in front of them, like a bus or a lorry in front of them. Then it will become a high velocity
injury. Yeah, secondary impact. Okay. So that's all. So currently our patient is actually doing well in his post-op phase. Yeah.
So that fracture is fixed.
Fracture is fixed. Head injury, the repeat CTs are solving, resolving HDH.
Okay.
So
anything else you want to add? Nothing. So our duty is to stabilize the wound. We cannot do anything for the wound, but if we have to stabilize the wound. We have to avoid complications because of wound. That is our duty, and we have to monitor the airway, breathing, circulation part as a ER physician.
If it is an open injury, then we have a role for IV antibiotics.
Okay, tetanus
And tetanus globulin.
Tet
globe
has to be.
What is the dose of tet globe?
250 milligram.
250. Okay.
If it's a less contaminated wound, if it's a highly contaminated wound, it becomes 500.
Okay.
500.
Tetanus what is it? TT. Tetanus toxoid has to be given with tetanus immunoglobulin. Both has to be given.
Open injury, then proper washing has to be done.
Okay.
And empirical antibiotic covering the anaerobics and the normal commensals.
Okay, that depends on hospital. They have different protocols. What is a normal drug you give?
Here for anaerobic coverage, we can give metronidazole. For gram positive and negative, cefoperazone.
Or cefuroxime.
Cefuroxime is the ideal drug. Cefuroxime is the indicated drug in almost all trauma, but depending on the surgeon, it may change because cefuroxime is class 1 cephalosporin. Okay, it covers both gram positive and
negative.
Negative, it's not.
Anaerobes. And also, suppose the patient is this patient was
actually is very bad wound. Okay. Otherwise, it is not recommended.
Especially in this patient, we plan for surgery after 2-3 days. So we have to actually monitor for any worst chance of compartment syndrome. Which we have to monitor by like comparing the girth of both lower limb and also if you have any.
What is the what is the clinical sign of compartment?
One thing is actually exponential pain, like sudden
pain
is the out of proportion pain.
Whatever you tell, the edema, all these things it can be there. Even like a patient who is having CLD, all these things will not work. But the pain disproportionate to your problem, that is compartment syndrome.
Which we can actually elicit or even worsen by active or passive movement of the muscles also.
Ideally, it should not be tried. All these things should not be tried. Pain is the most important thing, which will tell you the compartment syndrome. And there are some devices available which you can assess the compartment, measure the compartment pressure. But we don't have that.
outside we have something called a striker kit, which we have a small needle and a pressure gauge.
Pressure gauge is there.
So anything less than 30 is safe. Anything above 45, we have to think about going for fasciotomy.
Okay.
Fasciotomy is indicated in injuries less than 48 hours. Beyond that, there is no point in going for procedure. If we, before the 48 hours we are detecting a compartment injury, we can go for fasciotomy to release some pressure. So that's all.
Okay. Thank you.